Next, we have Monica Girotra from endocrinology, who will be speaking about endocrinopathy with immune checkpoint inhibition. And we all know that this is one of the major problems because sometimes we believe that these are permanent toxicities. And as these drugs move into the adjuvant setting, and these patients may be living for many, many years after the treatment with checkpoint blocking antibodies, really important to think about the hormone system. So this will be our last talk right before the break. And David, great talk, and I'm sure you'll be appreciated for questions at the break time. Thank you.
Thank you for the invitation to speak today. So just briefly, my financial relationships. So the two main endocrinopathies we see after immune checkpoint inhibitor therapy are one, hypophysitis, typically induced by CTLA-4 antibodies, and two, primary thyroid dysfunction, which can be induced by PD-1 or PD-L1 antibodies, as well as CTLA-4 antibodies. The symptoms can be nonspecific, and endocrinopathies are often long-lasting. The pancreas and the adrenal glands are less commonly affected. Just to go through briefly the role of the pituitary in regulating other organs, the pituitary gland makes ACTH, which can stimulate the adrenal gland to make cortisol. It can make TSH, which can stimulate the thyroid gland to make thyroid hormone. It makes LH and FSH in men, that which stimulates the testes to make testosterone, and in women to make estrogen from the ovaries. So you can imagine in CTLA-4 associated hypophysitis, many organ systems can be affected. The incidence of hypophysitis is estimated at approximately 10%. However, it's rare with anti-PD-1 therapy alone. The onset of symptoms can range for anywhere from 6 to 12 weeks after treatment, but patients may present as early as week 4 or as late as week 16. Most common symptoms include headache, fatigue, muscle weakness. Again, these can be nonspecific and may be misattributed to the general symptoms related to cancer. Less frequently, you can have nausea, anorexia, weight loss, visual changes, changes in mental status, temperature intolerance, and arthralgias. Hyponatremia has also been reported. The morbidity of hypophysitis is predominantly related to secondary adrenal insufficiency, which can be life-threatening if not treated. Levothyroxine is used to treat secondary hypothyroidism from hypophysitis. In patients with both ACTH and TSH deficiency, glucocorticoid replacement should be initiated prior to or at the same time as thyroid hormone replacement in order to prevent precipitating adrenal crisis. Hyponatremia is typically temporary and improves after adrenal hormone and thyroid hormone replacement. Testosterone can be used in men who develop hypogonadism and in estrogen in premenopausal women. Diabetes insipidus in these patients are uncommon. We tend to reserve high-dose steroids for patients with severe illness, significant hyponatremia, severe headache, visual abnormalities, or significant pituitary enlargement. In retrospective studies, high-dose steroids do not seem to reverse hypopituitarism. There's also the concern that the immunosuppressant effect of high-dose steroids could negatively affect anti-tumor efficacy. Steroids can decrease pituitary size gradually and relieve symptoms, and this can be done even with low-dose steroids. Steroids used to treat adrenal insufficiency typically are hydrocortisone 10 to 20 milligrams in the morning and 5 to 10 milligrams in the PM. This is equal to about 4 to 7.5 milligrams of prednisone a day. We do provide our patients with adrenal insufficiency teaching for increasing steroids during illness or for surgical procedures. The majority of our patients do not show signs of HPA axis recovery at long-term follow-up and remain on physiologic doses of steroids and levothyroxine if needed. Screening for secondary adrenal insufficiency is often not a component of routine monitoring after CTLA-4 blockade. We do recommend the consideration of routine monitoring with early morning ACTH and cortisol levels, as well as TSH and free T4 at baseline and during treatment, for example, monthly during the first 6 months. If the results are normal and the patient is asymptomatic, testing can be spread out to every 3 months for the next 6 to 12 months, followed by further testing every 6 to 12 months thereafter. If there are signs of hypophysitis or hypopituitarism, a prompt evaluation is needed, including early morning ACTH and cortisol, as well as TSH and free T4. A cosentropin stimulation test is not very useful in diagnosing early secondary adrenal insufficiency. In patients with hypophysitis or hypopituitarism, we do suggest obtaining an MRI of the pituitary gland, as well as at some point assessing levels of gonadotropins and sex hormones. This is part of an algorithm that we recently published in JNCI Cancer Spectrum. It goes through the monitoring that I just outlined. However, it also goes through some of the lab abnormalities we can see. So for example, if you see a low cortisol and a low ACTH, that's consistent with secondary adrenal insufficiency from pituitary damage. If you have a low cortisol and a high ACTH, that would be consistent with primary adrenal insufficiency. Primary adrenal insufficiency is rare in these patients, and that would be a direct effect on the adrenal gland. If you have a low or normal TSH with a low free T4, that would be consistent with secondary hypothyroidism from damage to the pituitary gland from hypophysitis. Looking now at primary thyroid dysfunction, we most commonly see thyroiditis in these patients, which is thyroid inflammation, which results from leakage, which can result in leakage of thyroid hormone or thyrotoxicosis, which can result in permanent damage to the thyroid gland and subsequent hypothyroidism. Graves' disease in these patients is less common. It's important to distinguish primary thyroid dysfunction from thyroid dysfunction secondary to hypophysitis. So in primary hyperthyroidism or thyrotoxicosis, you have an elevated to normal free T4 from the thyroid gland that suppresses pituitary TSH. In primary hypothyroidism, you have a low T4 or T3 that elevates TSH secretion from the pituitary gland. In hypothyroidism secondary to pituitary dysfunction, you have a low to normal TSH, but that's not enough stimulation for the thyroid gland, which results in a low free T4. T3 levels in patients with acute illness can be inaccurate. Primary thyroid dysfunction and CTLA-4 blockade alone has been reported in approximately 5% of patients. In a review of clinical trials using ipilimumab without PD-1 blockade, primary hypothyroidism presented out anywhere from 5 months to 3 years after therapy. Looking at thyroid dysfunction and PD-1 or PD-L1 antibodies, initial studies showed hypothyroidism at approximately 5 to 8%, hyperthyroidism at approximately 3%. However, in more recent detailed studies looking specifically at thyroid dysfunction, it may occur anywhere from 14 to 20% of patients. In 14 to 20% of patients. The typical onset of primary thyroid dysfunction after anti-PD-1 treatment, so thyrotoxicosis that progresses to hypothyroidism at 3 weeks with a range of 3 to 21 weeks, hypothyroidism at 6 weeks, with a range of 3 to 40 weeks, isolated thyrotoxicosis at 8.6 weeks with a range to 6 to 11 weeks. Primary thyroid dysfunction can be subclinical and detected only via laboratory tests. However, hypothyroidism can present with fatigue, muscle weakness, cold intolerance, bradycardia, thyrotoxicosis, tremor, weight loss, palpitations, heat intolerance. Thyrotoxicosis, fortunately, is usually transient and can be managed conservatively. Sometimes we can use beta blockers for treating symptoms such as tremor or tachycardia. However, the majority of patients are relatively asymptomatic. Hypothyroidism is replaced with thyroid hormone. Obviously, we monitor patients during treatment for signs and symptoms of hypothyroidism or thyrotoxicosis. In addition to baseline TFTs, such as TSH and free T4 before initial therapy, subsequent TFTs can be measured, for example, monthly during the first 6 months, then every 3 months for the next 6 to 12 months, and then every 6 months thereafter. Here's the thyroid portion of our algorithm, looking at the screening and management of PD-1 or PD-L1 associated thyroid dysfunction. So again, the monitoring that we just talked about, but then again, looking at the labs. So if you have a high TSH and a low free T4, that's consistent with primary hypothyroidism. If you have a low TSH and a high free T4, this is consistent with thyrotoxicosis, which most likely is from thyroiditis. In this setting, we do recommend monitoring patients every 2 to 3 weeks for the development of either primary hypothyroidism or in some patients, normalization of their TFTs or persistent thyrotoxicosis. In patients with a low or normal TSH and a low free T4, this would be considered consistent with secondary hypothyroidism. And again, that's rare with anti-PD-1 or anti-PD-L1 therapy alone. Moving to checkpoint inhibitor-induced insulin-dependent diabetes. It is more rare, but since we've been using these drugs so often now, we do have a large cohort of these patients that we've been following. However, the overall incidence is estimated less than or equal to 1%. It's associated both with anti-PD-1 or anti-PD-L1 agents. It's rare with CTLA-4 blockade alone. Patients can present from less than 1 month after drug exposure to 12 months after drug exposure. So obviously, given the morbidity related to DKA and hyperglycemia, we should be aware of this side effect. Patients can present with new onset hyperglycemia or DKA. Typically, this is very obvious in at least the insulin-dependent cases. So patients present with glucoses in the 400 to 500 range or in frank DKA. Patients are insulin-dependent. They have low C-peptide levels. They may or may not have autoantibodies. Approximately 40% of our cases tend to have positive autoantigens. 40 to 60% of patients can actually have an elevated amylase and lipase, which points to a role of pancreatic inflammation. These patients remain insulin dependent over time. So in summary, immune-related endocrine events with these agents most commonly affect the pituitary and the thyroid gland, but other target organs can be affected. There's an increased susceptibility to hypophysitis in patients treated with anti-CTLA-4 therapy. Anti-PD-1 and anti-PD-L1 treatment is predominantly linked to primary thyroid dysfunction and less commonly insulin-dependent diabetes mellitus. Immune-related endocrine events are often irreversible, and management typically requires hormone replacement. However, in most cases, we do try to continue treating with immunotherapy, especially if patients are deriving clinical benefit. Thank you.